Okay, hello everybody, and thank you for inviting me. I'm going to talk about slim and ultra-slim scope for peripheral nodule diagnosis. This is my conflict of interest. So, what is out there regarding scope? We are all used to the therapeutic 6 millimeter scope. We can get maybe up to the lobar and maybe segmental bronchi. We all know the diagnostic 5 millimeter scope. We can get out maybe to the 4, maybe to the 5th, 6th generation, but not further. And then came the thin scopes, the Olympus BFP 190, which has a 4 millimeter outer diameter and 2 millimeter working channel. And this scope can go up to maybe 7, 8 generation. And then the Olympus BFMP 190, which has a 3 millimeter outer diameter and 1.7 millimeter working channel. This scope can actually go all the way to the pleura or all the way to the peripheral nodule, as you will see next. Fuji also came with a 4 millimeter scope, quite comparable in specs to the Olympus BFP 190. I have no experience with this scope, but it should be the same. We had the XP 190 2.8 millimeter outer diameter scope for a while, but this scope has a 1.2 millimeter working channel, which is not enough for our working tools, and especially for the rebus with the radial ultrasound that I think is a must for peripheral navigation. So now we have a new disposable kits on the block. I was waiting for those to come up since COVID and the explosion of disposable scopes, and the first one who came up was the Vitin IP. I have some experience with this scope. The specs of the scope are similar to the BFP 190. You can even lock the lever and spin the neck of the bronchoscope. So you have no fear of pushing tools through tight U-turns, because you can ruin the scope. You just throw it afterwards. You can lock the lever. But in my personal experience, this scope is not as good as the reusable scopes. If you have tight turns, especially in the upper lobes, it's maybe difficult to insert the scope into the relevant airway. It can fold upon itself. But in certain anatomic conditions, in certain anatomic locations, you can use that, and it's good to have in your toolbox. Recently, AMBO also came with a disposable scope with similar specs. I have no experience with this one. Now, if we compare thin scopes to robotic scopes, which are also used to navigate the periphery, the Auris distal scope and the Galaxy NOAA has the same specs as the Olympus BFP 190, which is its outer diameter around 4 millimeter and working channel around 2 millimeter. And then if we go to the thinner scopes, we have the Olympus BFP 190, which has a 3 millimeter outer diameter. And remember that the thinnest robotic scope that we have has an outer diameter of 3.5. But the difference between them is that with the ion, you don't have peripheral vision. That, in my vision, is very important for navigation. If you want to put your tools inside the ion, you have to pull your camera out, and you lose distal vision. With the Olympus BFP 190, you have vision all along your bronchoscopy, distal vision. And what tools can we use with the thin scopes? We can use all the tools. We can use the PeriView 21 GE needle. We can use the dedicated Olympus forceps, and of course we can use both cryoprobes with the 4 millimeter scope, and we can use the 1.1 with the 3 millimeter scope. Now, if we will compare the different platforms from other aspects regarding price. If you compare it to robotic scope and electromagnetic navigation like Illumisight, the price is very low. regarding the other platforms. And even the disposable price, if you use a reusable thin scope, you just pay for your sampling tools, but in other platforms, the cost can get up to $2,000 per patient, which is a lot if you have a high volume, if you are a volume center. Tip flexion, very important. You can flex the tip of your scope in the periphery as you can do with the robots. If you use electromagnetic catheter-based navigation, you cannot control the tip of your catheter. Navigation, you have, of course, you don't have navigation in slim scopes. I will talk about it in a minute. You have it in all the other platforms. Peripheral vision, very important. You have no peripheral vision with catheter-based navigation. You have it with Monarch, Galaxy, Ion. It is alternating, but you have it all along the way with thin scopes. Bleeding control, even if you go after peripheral nodules, I think everyone who's done enough procedures like that encountered bleeding which is more than mild. So if you are in with a reusable slim scope, you can immediately try and control it and wedge. With the other platforms, I guess you have to pull the scope out and put in another regular scope in, which takes time. Haptics, very important. You don't have it with the robotics and not with the catheter-based navigation, but you have it with the slim and ultra-slim scope. Regarding stability is very important, and you can get that with slim scopes using various stabilization arms, like I use the Mediflex one, and it's very stable. So, regarding the difference in reach between slim and ultra-slim scope, there is a study from Oki et al., and he was comparing the reach of the ultra-thin and thin scopes, and he found that the thin scopes can go to a median fifth versus median fourth. The ultra-thin scopes can go to median fifth versus the fourth generation with the thin scopes. It means a difference of one airway generation, which is not a lot, but our experience is quite different. Our experience that you can go more than one airway generation. You can go two to three airway generation further. And this is probably because in this study of Oki, he was using conscious sedation. So I think part of the airway were collapsed. We use general anesthesia with a special navigation ventilation protocol for every navigation. So this is why probably we can go further. You can see here at the bottom the difference you can in reaching this right upper lobe nodule between the 4 mm scope on the right and the 3 mm scope, which can go much further and reach the nodule, and you can even see the nodule with your eyes and take a biopsy. Now, this study was actually comparing the reach of the Monarch robotic bronchoscope with the Olympus BFT 190, and the finding is, and they were trying to get into LB1, okay, in the upper lobes, and they found out that the robotic scope can go to a mean generation count of 8 versus 4.5 with the BFP 190. But if you just read this paper, the way they were pushing the BFP 190 is not by actual navigation or under vision. They were just pushing a stylet into the right upper lobe, and then on that stylet they were pushing the BFP 190 until they could not push it anymore. So they were not really navigating the airway under vision. And if you look at the upper right of the screen, the upper row is where where the BFP 190 could go, and the lower row is where the bronchoscope, the Monarch, could go. You can see the difference. But if I will take my cases from thin and ultra-thin scopes to similar anatomic location, you can see that if you actually navigate the scope, you can get much further, and the images below are quite similar to the images of the monarch. So this is for this you have to actually navigate under under vision, and this is an example of this. You can see that RB6 nodule on the right, and you can see the video when you are actually using the MP 190, and you can count the number of airways that you are passing. This is the main bronchi, bronchus intermedius, RB6, and you can count the number of airway that you can go, and you actually see. You can actually, here you see it again, you can actually see the nodule and sample it. It turned to be adenocarcinoma. So a lot of what we used to call TBB under vision becomes endobronchial biopsies. And I'm sure that everyone will agree that it doesn't matter what platform you use. When you integrate it with advanced intraprocedural imaging and get augmented fluoroscopy and tool-in lesion imaging, you increase your yield by 10 to 20%, and this is the same with thin scopes. So we can integrate thin scopes with cone beam CT. This is from my institute. So you can see here this Cheerios-like GGO on the upper row. You can see the virtual image. This is the same workflow as you do with robot and cone beam CT. And on the right, upper right, you can see tool-in lesion. The same with the lesion on the lower row. And this is how it's done. I'm sure that you will all agree that this target here is a robotic target that everyone probably will use in the US, a robot to get there, but you can use cone beam CT and thin scopes. This is the virtual nodule after marking it with cone beam CT segmentation. Once you get there, you can confirm by turning the C-arm that you are not superimposed on the lesion, but you are actually in the lesion. And I think that even though we have that, radial ultrasound is essential because except CT to body divergence, you also have intraprocedural divergence, and this is because during the procedure the nodule position is changing all the time. So instead of just chasing the nodule, you can just confirm it with radial EBS that you are in place. And this is a tool-in lesion done with, this is not a robotic scope, this is a thin scope. And you can see the tool-in lesion exactly like you would have with robotic bronchoscopy. Of course, not everyone gets access to cone beam CT, so I use cone beam CT as well in lung vision, and you can have the same products in lung vision. And this is an example of a lesion adjacent to an aortic arch. You have very tight turns there, and of course you don't want to sample the aortic arch or puncture it. So with lung vision, this is not a lecture about lung vision, but this is an example what lung vision can do. I use lung vision exactly as I use cone beam CT, the same workflow with thin scope. And here you can see how the thin scope's taking this tight turn. I think this is the MP130, and you can see the biopsy. This turned out to be adeno-CA, and you can see here the tool-in lesion. I did that before lung vision had the AI tomo, so I don't have the axial view, but now you can have this in axial view exactly like in the cone beam CT, and this is the sampling. How do I get there? you can use various virtual bronchoscopy platforms like LungPoint, or even now LungVision has a very good virtual bronchoscopy navigation, so you can use that. Or you can use the Kurimoto airway tracing. I think this is the next lecture, so you will hear about, from Dr. Ko about it a lot. What I use is mental navigation. So you have to train your brain by looking at the CT in MPR, multiplanar reconstruction, and high resolution slices of 1 millimeter, and then you build a mental airway mapping. And this takes training. So I guess that if your first steps with a fellow, when you are a fellow in peripheral navigation, if they hand it, if you got the robot in your hand from the first steps, you probably will never develop it. But in other places, they train you to actually reconstruct the airway in 3 dimensions, and to actually vision what would be inside the airways by looking at the CT. And if you do this from the start of your fellowship, and then do a lot of navigation using mental navigation, then you will develop this way of doing things. So tips and tricks for peripheral reach: general anesthesia, ventilation, navigation ventilation protocol. We use like 60 cc per kilogram, PEEP of 10 to 15. It depends if it's the upper or lower lung or lobes, or if the patient is obese. FiO2 lower than 50, and endotracheal tube of 8.5. You start navigation as soon as possible before atelectasis set in. And you can use lung recruitment maneuver. You can use both 3 and 4 millimeter scope. I always use both of them. If you have atelectasis, you can use gentle air injection to open the collapsed airway, like you see here in the two pictures on the right. And scope stiffness can be controlled with different tools inside the working channel. So you can actually move forward your scope on top of your tool to reach places that the scope will not go in itself. And this is my last few slides that shows the importance of peripheral navigation, of peripheral vision, because sometimes you can also see the etiology, not just the tumor itself. For example, this left upper lobe nodule on the left. Here you can see navigating with an MP using LungVision, augmented fluoroscopy. You can actually see the nodule and do an endobronchial biopsy. And on the example of the right, you can actually see no airway going to this tiny left upper lobe nodule, but when you get there with the MP scope, you can see multiple very tiny, maybe 1, maybe half millimeter airways. All of them are going to the same augmented nodule. But if you now use a radial ultrasound and stick it to, and push it to each one of them, only one of these holes produces the image that you see in the lower right of the picture. And then if you use your forceps to get into this same hole, then you get a diagnosis, and this was a squamous cell carcinoma. Another time, a nodule is not really a nodule, okay? Like this right lower lobe nodule, you get in, you find a space full of fluid. We could not guess it by CT by measuring the household unit. And once you get there and the fluids come out, then you lose your radial ultrasound image. And if you repeat the CT, you see that this nodule actually disappears. And if you have peripheral navigation, peripheral vision, you know why. Another example of this right upper lobe PET positive nodule, when you get there, what you see is a very small carcinoid. This airway is maybe 3-4 millimeter in diameter, and this is a round carcinoid on a stalk. We took it out, and actually everything behind that was post-operative infection. So this is not really a nodule, although it's best positive and very, very suspicious. And this is, I think, my last slide. This lady came to me with after she with a lingular nodule, and she was about to be operated to get a lingulectomy, and she came for second opinion because they told her that this could not be navigated. So we navigated there with a thin scope, and we saw this nodule in our eyes, and we took a lot of cryobiopsies. Okay, this is an example that although you are using a thin scope, you can take a significant amount of material for all you want. This turned out to be an hamartoma, and we took, I think, all of it out. And of course, we didn't recommend any follow-up CT, but someone sent her to a follow-up CT, and you can see here that it disappeared completely. And this lady could easily gone through a VAT surgery for nothing. So this is my last slide. And so to summary, slim and ultra-slim scope is good option for peripheral pulmonary lesions sampling because of excellent peripheral reach, continuous vision, tip flexion and tool deflection correction, good selection of sampling tools, immediate bleeding management. It's relatively cheap and can be used with various navigation systems. It works great with advanced real-time imaging like digital tomography and cold beam CT, but it's not a plug and play. So you cannot just start doing navigation. You have to train yourself, and then you develop this capability of navigating to very small nodules in the periphery. Thank you, and thank you for inviting me.